Marcy has pointed out, the most important thing is fibrosis risk stratification. It's given you a very good paradigm on how to kind of identify those that are low, intermediate, and high risk. But when it comes to therapy, there are some global approaches across the board, right? So there's going to be general lifestyle changes, dietary recommendations, exercise, limitation of alcohol use, and of course, weight loss. And weight loss certainly becomes more important as you have more and more advanced disease. And we're going to go into these in a little bit more detail. So in terms of the type of diet for the treatment of MASLD, in the colors, you have the level of evidence. So thus far, the Mediterranean diet has the most data supporting its recommendation, followed by a low-fat or low-carb diet. More specifically, when you look at meta-analyses, it includes 6 randomized controlled trials where patients received either the Mediterranean diet or no intervention or other diets such as low-fat diets, and they had duration of 6 weeks to 6 months. You can see those that were on a Mediterranean diet had reductions in liver stiffness, fatty liver index, and HOMA-IR, a marker of insulin sensitivity. And there's a lot of talk about intermittent fasting, right, on the internet. We can talk about 3 different types of fasting. So there's the alternate day fasting. There's the 5-2 fasting, which is when you eat kind of normally for 5 days, and then for 2 days, you're very restricted, less than 500 calories each day. And then the time restricted dieting, when you eat, 16 hours and then fast the remaining. Fast the 16 and eat the remaining. And these 3 main forms of intermittent fasting do produce 3 to 8% weight loss over 8 to 12 weeks. And they've been shown to decrease liver steatosis and liver stiffness. However, it's very similar to that which you can achieve with a daily calorie restriction. So I think at this point, the ability of a specific type of fasting and its implications for long-term impacts on MASLD are unclear. The message is whatever a patient can adhere to. If that's something that they can do and they can sustain and it results in weight loss, at this time, that is the best recommendation. Now, what about ultra-processed food? Now, this was an interesting study done at the NIH where they took 20 inpatient adults and they gave them an ultra-processed diet and an unprocessed diet. And that diet was matched for calories, sugar, fat, macronutrients, and fiber. But they could also eat outside of the diet that they were provided. And what they found was those that were on the ultra-processed diet kind of ate more outside of those of what they were given on an average of 500 calories per day. And so over the time period of just 2 weeks, they had a 1 kilogram increase in weight. And so limiting the consumption of ultra-processed foods may be an effective strategy for obesity prevention and treatment. The efficacy of limiting the consumption of ultra-processed diet in MASLD needs to be assessed. But certainly we do recommend the more farm-to-table approach. Now, in terms of exercise, the American College of Sports Medicine got together recently in a roundtable and made some recommendations around physical activity and MASLD. And they recommend at least 150 minutes per week of moderate intensity aerobic exercise or 75 minutes of more vigorous activity coupled with resistance training. And I want to spend a moment on that. We know that many people have sarcopenic obesity. And we also know that sarcopenia is associated with poor outcomes, liver-related outcomes. And so it's critical that when you recommend weight loss or any kind of exercise program, that you also include resistance training to maintain muscle mass. Muscle mass is extremely important for lipid metabolism, insulin sensitivity, and particularly with some of the pharmacologic approaches that are out there now for weight loss, there is a concern about sarcopenia. So always having that conversation about concomitant resistance training is critical. And so in summary, we have overweight, obese, MASLD. Of course, you want to recommend at least that threshold of 10% weight loss, which has been shown in many studies to be associated with fibrosis regression. Importantly, even those patients with non-obese MASLD, they have visceral adiposity, even though their BMI may be less than 25. 3 to 5% reduction in body weight is still associated with improvement. And so we still want to recommend that even in those patients. We want to reduce added sugars. Sweetened beverages, I didn't talk about fructose or added corn syrup, but there is some suggestion that fructose can promote de novo lipogenesis in the liver. And so we recommend no fructose containing beverages. Of course, reduce saturated fat and cholesterol. I mentioned that Mediterranean diet, the recommended level of activity, as well as staying away from processed foods, limiting alcohol intake. So we know that diet and exercise is great, and it is the cornerstone of everything we do with our patients, but sometimes it's not enough. And so there are pharmacologic approaches to weight management, and they're ordered here by the level of weight loss reduction that they cause. So down on the bottom, tirzepatide has been shown to cause about 18 to 20% weight loss, which is approaching what you get with surgical approaches. You're going to hear at 4 o'clock today some endoscopic approaches for weight loss. And of course, as I've said, surgical bariatric surgery has been shown to decrease fibrosis, so cause fibrosis regression, has been shown to decrease liver and cardiac related mortality, as well as all-cause mortality. And so now we know that Dr. Anasi pointed out very well how prevalent this disease is in diabetics. So we want to make sure that we are managing their diabetes. And there are certain medications that are for diabetes that may also have secondary effects on the liver, specifically pioglitazone, SGLT2 inhibitors, and the GLP-1 receptor agonist family. They've all been shown to improve steatosis and steatohepatitis, though at this point, the trials are happening, and we'll go on to those a little bit. They have not yet shown fibrosis regression. You need to be a little bit cautious once patients have cirrhosis, but they're generally safe. And definitely you want to be very cautious in those with decompensated cirrhosis.